So my talk is on ACL avulsion fracture. It's a similar talk to Dr. Sujit's talk, but its fixation method is with a screw. So my initial few slides might be quite similar to Dr. Sujit's. So I'll just go through them quickly. So one of the most common knee pathologies, well described in literature, both in pediatrics and adult population, commonly seen between the age group of 8 to 13, and it's in adults. It's commonly related to high energy trauma or a road traffic accident. Uh, Increased incidence amongst children, it is secondary to the relative weakness of incompletely ossified tibial eminence compared to the native ACL fibers. Classification, Mayers and McEvers and Zarizin, I can't really pronounce that name really. So it's type 1, type 2, type 3A, B, and the fourth one was described by Zariknen. So type 1 is fractures with no displacement. Type 2 is where anterior third or half of it is displaced or hinged. Type 3A is the most commonest one, which is fractures with completely displaced fragment. Type 3B is displaced with rotation, and type 4 is fractures with a displaced and comminuted fragment. So ACL avulsions, first thing is you do an X-ray to rule out any other bony injury and anatomy of the native ACL avulsion fracture. MRI scans to see for any intrasubstance tear in the ACL, associated meniscal injuries or collateral ligament injuries. CT scan is to see the type of the fracture, displacement, and associated bony injuries. Multiple ways to skin a cat. So arthroscopic or open with screws, sutures, pins, and wires. So open technique nowadays nobody does. Most of them are arthroscopic. Uh, so the tips in fixing these fractures are be as close to the center as possible, as anterior as possible. Avoid any kind of impingement. Fix the anterior fragment mainly, and you should be aware that the fragment should be at least 3 times the size of the screw diameter. Surgical techniques, supine position. I usually do it by hanging by the side of the table. Knee flex to 90 degrees. Arthroscope is introduced through the anterolateral portal, and the hook probe is used through the anteromedial portal. 1.25 mm threaded guide wire is introduced through the superior anteromedial portal and drilled in the anterograde superior anterior to inferior posterior direction to fix the fragment in position. A 3.5 mm cancellous screw and washer are placed intraarticularly, and the fragment is fixed to the tibia over a guide wire, which is then removed. The direction of the screw should be from the center of the fracture fragment to the posterolateral cortex of the tibia at an angle of about 45 degrees to the coronal and the sagittal axial plane. So this is how we do it. So already the reduction technique has been demonstrated by Dr. Sujit, so I won't go too much through that. It's a simple technique. Just reduce the fragment, put in the guide wire, and put in the screw. Only one tip which you need to understand is whenever you are going to reduce these fragments, you have to make sure that these fragments, usually the meniscus comes in between these fragments when you're trying to reduce. So you have to take that meniscus out of the position, put a guide wire to keep that meniscus in position, and then reduce the fragment. You may also have to take out the intermeniscal ligament also in these times, because if it is there, the reduction becomes really tough. So that's how you are going to see it in the C-arm. 3 guide wires, one is holding the meniscus, the second is holding the fragment, and the third is the actual guide wire, which is going to be for the screw itself. This was a case, fortunately, I got to do it yesterday itself. So why arthroscopy? It's the less invasive, minimal soft tissue handling, and causes less stiffness also. Advantages: it provides direct compression fixation across the fracture, avoids placing the sutures through the ACL. Disadvantages: fracture fragment may be too small to accommodate the screw. Second, surgery for the removal of the screw, growth disturbance in pediatric due to damaged epiphysis. So we did a study in between about these ACL fractures which were fixed with screws. So the mean age group was around 8 years. Most of the fractures were type 3, and the mode of injury was sports injuries in most of the cases. Complications: cartilage damage was seen in 4% of the cases, osteoarthritis in 2%, tibiofemoral arthritis none of the cases. So post-operative rehab, we can go ahead with the rehab very quickly in screw fixations. Immediate post-op range of motion can be started once you are sure that your fixation has been quite good, and we can give a range of motion brace and start the mobilization of the patient. So a couple of papers which showed that anterograde fixation, screw fixation with washer was most effective technique to obtain initial rigid fixation. This was a paper by Sukada. Retrograde screw fixation, the use of this fixation technique might be restricted when the fragment is thin or comminuted. Uh, Another paper by Muhammad Ayal, the choice of fixation device for treating ACL avulsion fractures remains a subject of debate, and the decision should be based on the patient's situation and the surgeon's expertise. Another paper showed that it is recommended to use the 3-point fixation for proper posterior reduction and creation of compressive area between the fragment and its base. Another paper showed about staple fixation. So you might use, so as I told you, different techniques can be used to reduce this fragment and fix them. So multiple ways to do this surgery. Thank you. With that, I end my talk.